So I'll be discussing actually a very simple case of a patient who comes to us almost day in and day out in our clinics, of a patient with diabetic retinopathy with diabetic macular edema. So going straight to the case, we have a 53-year-old male who has been referred to us by an endocrinologist for fundus evaluation and was diagnosed with diabetes mellitus type 2 10 years ago. The patient was on irregular follow-up with the endocrinologist with chief complaints of blurring of vision in the right eye for the past 1 month. In the right eye, he was seeing 618 and the vision in the left eye was 69. The anterior segment examination did not show any iris neovascularization. And since this is for the comprehensive ophthalmologist, I would like to stress upon the INVs because often we get patients in whom we may not have very impressive posterior segment findings, but this is something that we need to focus on. And you may have angle neovascularization or iris neovascularization in these patients. This is the fundus image of the patient of the right eye, which shows us presence of hard exudates right in the center. And there are microaneurysms which are involving just near the foveal center. The left eye is slightly better, where you have fewer hard exudates which are involving the center of the macula. I just wanted to include this slide to show us that in patients with DME, diabetic retinopathy, this is the classification that we usually follow. We'd like to look at the microaneurysms, and if there are only microaneurysms, we call it mild NPDR. But this patient clearly had more than microaneurysms and had hard exudates, and so comes under moderate NPDR. I would also like to highlight what is called as the OCT-based classification of DME, which is not based on CSME, and which essentially means that this is something that we follow nowadays in our clinics, where we would like to call the edema as either center-involved DME, when it is involving the central 1 millimeter, pericentral inner involved DME based on the ETDRS inner circle, or pericentral outer involved DME. Based on the amount of edema, we can call it, we can quantify it based on the thickness, volume, and looking at the other parameters of these subfields. We also look at various vitreoretinal interface abnormalities, such as epiretinal membrane, posterior hyaloid detachment, if they're present, absent, or incomplete, and presence of hard exudates in the central subfield. Now, hard exudates is something that has been recently shown to be very important in the prognostication of patient and in the decision making for the use of therapeutic agent in these patients. The fluorescein angiography in these patients, I think at baseline is very important because it tells you the location and presence of the microaneurysms and whether they're leaking or not. As you can see in this patient, there are certain microaneurysms which are very near the foveal center and some of them are slightly away. And it's important to follow them in the late phase, and you realize that not all the microaneurysms are leaking in the late phase. And these are the microaneurysms that you would like to identify and treat if you're going ahead with focal laser. But in this particular patient, you can clearly see that there is significant leakage in the center, and probably on the OCT, you're expecting a significant thickening. Sure enough, you also are going to update fields to see if there are any NVE which may be occult and which you may have missed clinically. The left eye also has microaneurysms which are closer to the center, and these of course are leaking in the late phase. The OCT, I'm just showing the right eye here because that's the eye of interest, and you can see that there is presence of hard exudates which look like these hyperreflective dots in the center. Now, if you exactly are able to co-localize these hard exudates in the center, then you would realize that some of them do not correspond to the hard exudates. And these are actually called as the hyperreflective foci. So hyperreflective foci are those hyperreflective dots on the OCT which do not exactly correspond to the hard exudates. In addition, you have cystoid spaces which are also involving the outer layers, and you have a very much an intact outer retinal layer, including the RPE, the photoreceptors are all intact, And the inner retinal layers, you are able to identify all of them individually. And so I can confidently say that this patient does not have drill or what is called as disorganized inner retinal layers. Similarly, this patient has an intact outer retinal layer and the ellipsoid zone, the photoreceptors. Now, of course, when you treat these patients, you would look at this image does not belong to this patient, but it's just to show that you can use fluorescein angiography to actually follow up these patients and see for the improvement in the microaneurysms. And of course, you can use your OCT angiography to detect microaneurysms, although OCT-A is not a great tool for microaneurysms, but rather for the avascular zone. You can also look at the fluorescein angiography at baseline to determine whether there is presence of macular ischemia. As far as investigations, these are the panel of investigations that we would like to get done at baseline. And among these, the most important ones that I feel I've highlighted include the HbA1c, the cholesterol levels, hemoglobin, triglycerides, and 24-hour urine protein, which give us the systemic control of these patients. And sure enough, this patient has a deranged systemic profile. So apart from treating the ocular disease, we are going to treat the systemic condition in this patient with lifestyle modifications, metabolic control. And this patient, we decided to use anti-VEGF therapy. With ranibizumab, left eye did not have edema, so was kept under observation. And often we start our patients with atorvastatin, especially if there is hyperlipidemia, to take care of the systemic control. And this is the follow-up OCT of this patient, and this patient actually did well. And we can go back and actually see that this patient had an intact inner layers and outer layers, and probably this is why this patient actually probably did well compared to a lot of other patients that we see in our clinics. Thank you very much.